Thank you for kind introduction. At the outset, let me thank the organizers of JPEF, Professor Jyotidev, Sunita ma'am, Gopika, and all the team for inviting me to Trivandrum to deliver this lecture on a topic regarding which we have some recent data to share, and that's why I selected this topic. And I find that it goes in really well with the overall theme of this conference, which is weight. You can say weight or WEIGHT also. So I'll be talking briefly on the current classification of obesity. I know that previous session we had a few discussions on that, so I won't go into great detail into that. But then I will discuss some data we have from a population-based study in India regarding the various phenotypes of obesity that we find in this country. I have no conflicts of interest to declare, and you may take photographs if you so wish. So I don't need to tell this audience that the burden of obesity and diabetes is increasing exponentially, and it's not just in one part of the world but throughout the world, but the burden is disproportionately borne by developing countries such as those in Southeast Asia, Latin America, and Africa. Traditionally, obesity has been defined on the basis of body mass index or BMI, which is nothing but a calculation, a ratio which utilizes your body weight and your height. And based on that, for Western Caucasian populations, we have various categories of overweight and obesity with cutoffs of 18.5 for healthy weight, 25 for overweight, and 30 for obesity. And within the obese category, you can have class 1, class 2, class 3, earlier which used to be called morbid obesity, super obesity, and so on and so forth. But we all know Asian Indians are different. And how are we different? And this has been discussed in terms of the concept known as the Asian Indian phenotype, or the thin fat Indian, which says that basically for any level of BMI, Asian Indians have more abdominal fat, they have more insulin resistance and hyperinsulinemia, higher levels of inflammation as measured by C-reactive protein, lower levels of adiponectin, which is supposed to be the good adipocytokine, and a characteristic dyslipidemia consisting of low HDL, high triglyceride, and highly atherogenic small dense LDL, and ultimately increase susceptibility to type 2 diabetes and coronary artery disease. Now, if you just take one of these risks, that is the incidence of type 2 diabetes. Now, this is data from a multi-ethnic population in the UK, which was published in the Lancet a few years ago. And this tells you the risk of developing type 2 diabetes by the BMI. And if you look here, you can see that all the ethnic groups, be it whites, Africans, East Asians, Islanders, all of them follow a certain trajectory, and South Asians are somewhere else. What this means is that Asian Indians with a BMI of 23 have the same risk of developing type 2 diabetes as a white Caucasian who has a BMI of 30. So we are different. And this is what led the WHO in the year 2000 to recommend ethnic specific cutoffs for BMI. And to my knowledge, the BMI cutoffs for an ethnic specific population have been published and validated only for Asian Indians, called the Asia Pacific Guidelines. And what this says is that if your BMI is 23 and above, you come under overweight. Remember, for West Caucasian populations, it is 25. And if you have a BMI of 25 and above, you are considered obese, which in the case of Caucasian populations is 30. But the problem is even this utilizes BMI. And you heard a very interesting lecture, a comprehensive lecture earlier saying that BMI should probably be thrown into the dustbin. And I will emphasize why in the next couple of slides. BMI is very useful, but it doesn't measure the amount of fat in the body. 1 kilo of fat and 1 kilo of muscle weigh the same. Like the old story of whether 1 kilo of cotton or 1 kilo of iron weigh more. 1 kilo of fat and 1 kilo of muscle weigh exactly the same. Even if you have excess fat, the BMI doesn't tell you where that fat is. Is it in the subcutaneous plane? Is it around the visceral organs? Is it inside the liver? Is it inside the skeletal muscle? The BMI doesn't tell you anything about that. And it doesn't tell you whether this excess fat is actually causing any trouble to that particular individual. So these are some of the limitations of BMI. Somebody with a BMI above 30 need not be unhealthy because their BMI may be contributed by the skeletal muscle. For example, people who are athletes. Conversely, somebody who has a BMI within the normal range may have excess fat. Their BMI may be low because they have sarcopenia. So BMI is not a good indicator of metabolic ill health. And that's why recently the Lancet Commission on Obesity has redefined obesity and classified obesity based on the health consequences to the individual. The first thing they did was they defined obesity, and they defined obesity as a condition characterized by excess adiposity, with or without abnormal distribution of function of adipose tissue, and whose causes are still poorly understood. Then they classified obesity into preclinical obesity or clinical obesity based on whether this excess adiposity is actually causing harm to the individual. So, do they have any disease or any organ dysfunction that can be attributed to this excess adipose tissue alone? And these are some of the examples given of organ dysfunction that can occur due to obesity. So, clinical obesity is a chronic systemic illness. It is no longer considered as a lifestyle problem. It is considered as a chronic illness characterized by alteration in function of tissues, organs, or the individual, which is solely due to excess or abnormal adiposity. But you also have a group of individuals who have excess adiposity but do not have any evidence of any organ dysfunction. These individuals are considered to have preclinical obesity. So you have defined obesity and you have classified it into preclinical obesity and clinical obesity. And this is a huge list of problems which can be used to make the diagnosis of clinical obesity in adults. You have n number of problems. And I would like to draw your attention regarding the hyperglycemia. So if anyone comes to you with diabetes, with an elevated BMI or any other marker of excess body fat, you don't have to look for anything else. That individual is having clinical obesity. When somebody doesn't have diabetes, you may have to look for many of these other disorders that you may get. So the first thing to do is to see whether the individual has excess body fat. And how do you see whether the individual has excess body fat? BMI alone is not enough. You need, in addition to BMI, one more measurement of body size, which can be the waist circumference, the waist-hip ratio, or the waist-height ratio. If you don't use the BMI, at least two of the other measurements of body size should be abnormal. And if you don't have any measurements of body size, you can also use some direct body fat measurements such as DEXA scan to detect excess adiposity. If you don't have excess adiposity, no obesity. If you have excess adiposity, obesity is present. The next thing to do is to see whether there is evidence of any tissue or organ dysfunction. Is there any sign, symptom, or any limitation of body function due to obesity? No, it is preclinical obesity. If there are signs and symptoms of organ dysfunction, ask the question, can these signs and symptoms be explained by the excess adiposity? If yes, it is clinical obesity. If no, it is preclinical obesity. If the individual has limitation of day-to-day activities, irrespective of any other signs or symptoms, you can make a diagnosis of clinical obesity. And these are the cutoffs for the various measurements of body size, which I do not have to explain more to this audience. Just to emphasize that for waist circumference, we have ethnic specific cutoffs for Asian Indians. For waist to hip ratio and waist to height ratio, the cutoffs are same for all ethnic groups. And to give an example, you have an individual with a BMI of 23.7. He doesn't have any evidence of excess body fat. He doesn't have any signs and symptoms. The old diagnosis, no obesity. For the new criteria also, no obesity. Another individual, 28.8 BMI, no excess body fat, no signs and symptoms. The old diagnosis would have been overweight. There is no category of overweight in the current diagnosis definition of obesity. Now it would be no obesity. The same individual, same BMI, but excess of body fat, but no signs and symptoms of organ dysfunction, it becomes preclinical obesity. Individual with BMI of 32.4, no signs and symptoms of excess of weight, no evidence of excess body fat, it is no obesity even if the individual has a BMI of 32.4. BMI of 39.2 with evidence of excess body fat, no signs and symptoms, preclinical obesity. Individual with BMI 39.2, signs and symptoms, it becomes clinical obesity. Of course, these BMI cutoffs are valid for white Caucasian population and not for the Asian Indian population. So we try to see whether these categories of obesity can be applied to the Asian Indian population. And we have this huge study called the ICMR INDIAP study. Most of you must be aware of it. And this is a study funded by the Indian Council of Medical Research. It's the largest epidemiological study done on diabetes in India. And we have sampled all the phases of the country, and most of the sampling is over, the study is over, and we have published the results in various phases. The total sample size is around 1.2 lakh individuals. And we have published data on the prevalence of various metabolic non-communicable diseases in India based on data from the ICMR INDIAP study. I will concentrate on the obesity findings. If you look here, generalized obesity based on the BMI cutoffs for Asian Indians, you can see that there is some heterogeneity in the prevalence of generalized obesity. such that the south and some parts of the north seem to be having high prevalence rates of obesity. The east, the west, the central and the middle part of the eastern part of the country like Bihar and Jharkhand tend to have lower rates. But remember that this heterogeneity is only for the rural areas. If you look at the urban areas, we are all in the same boat. And if you look at abdominal obesity, it is a very worrying picture. It doesn't matter where you are, urban area, rural area, everybody has high levels of abdominal obesity measured by an excess waist circumference. And this translates to 254 million people with generalized obesity, 351 million with abdominal obesity in the country. And do these numbers actually translate to adverse health outcomes? That's what we try to do in this paper, which is just out last week in the Indian Journal of Medical Research. And what we did here is that we divided individuals into 4 categories. Metabolically healthy non-obese, which is a reference group. They don't have any obesity. They don't have any evidence of metabolic dysfunction. Metabolically healthy obese, they have anthropometric features of obesity, but they do not have any clinical or biochemical features of metabolic dysfunction. Metabolically obese, non-obese, that means their BMI and other parameters are absolutely within normal limits, but they have some evidence of metabolic dysfunction. And metabolically obese individuals who are obese both by anthropometric and metabolic criteria. And these were all the criteria we used to define the metabolic dysfunction. And what we find is that we actually have a big number of metabolically obese but anthropometrically non-obese individuals in our country, close to 45%. And another 25 to 30% are metabolically obese. That means close to 80% of individuals in our country are obese either anthropometrically or metabolically. The metabolically healthy obese are very small in number. So that means if you have an elevated BMI, more often than not you are likely to be unhealthy. But if you have a normal BMI, it is very unlikely that you will be healthy. So that is what this data tells you. And if you look at the prevalence, state-wise prevalence, there is no prize for guessing who is first. Namada Kochi Kerala. Unfortunately, Kerala stands out with the highest prevalence of metabolically obese individuals, but none of the other states are too far behind. So we don't have to worry too much about the fact that Kerala stands first here. And more worryingly, look at the risk of adverse outcomes. Leave diabetes because elevated blood glucose has been selected as one of the criteria for metabolic dysfunction. But look at coronary artery disease, chronic kidney disease. The risk factors are as high, if not higher, for the metabolically obese, non-obese, as for the metabolically obese. So they're as badly off as individuals who are really obese by the anthropometric category. And these are people who get missed out if you look only at BMI. So what are the implications of our findings? If you use BMI, and I think you heard this from the first speaker today, if you use BMI as the sole criterion to diagnose obesity, the large proportion, 40% of individuals in India with the metabolically obese, non-obese phenotype will be missed out. And they will be denied the opportunity to participate in lifestyle modification, number one, and they may not be considered candidates for the newly available agents, which you have been talking about over the last 3-4 months ever since they became available in this country. And the interesting thing now, which will give some heart to patients with obesity, is that the latest ADA standards, and I believe that the ADA is now coming out with standards of care for obesity. They say when you treat obesity, you do not measure the outcomes by how much weight somebody loses or by how many units of BMI you come down. You measure your success by how much the comorbidities improve. So now the primary aim of treating obesity is not to bring down the weight, but to bring down the comorbidities. So that should give heart to some of our patients who are worried to start these agents because they are scared that they will lose too much of weight. So in conclusion, the prevalence of obesity is high throughout India in both urban and rural areas, and we have 254 million with generalized obesity, 350 with abdominal obesity. Over 43% of population in India is metabolically obese but have a non-obese range of BMI. And they have a distinct phenotype with metabolic consequences which are almost as bad as those individuals who are anthropometrically obese. So as we heard in the last talk, obesity goes beyond BMI. It is being recognized as a separate clinical entity. Adiposity, any degree of adiposity with the risk factors mentioned earlier, warrants follow-up. Adiposity is evidence of organ dysfunction, warrants treatment, and we have lots of treatments available now. And these newer definitions might be a first step towards precision diagnosis and management of obesity. We have precision medicine in diabetes, Now we are moving towards precision medicine in management of obesity. I thank you for your attention.
Thank you. Thank you very much.